Hi everyone, welcome back to our channel Magic of Medicine. In today's video, we will break down Ascariasis under clear academic headings, that is, etiology, life cycle, clinical features, complications, the diagnosis and treatment. So let's get started. Ascariasis is one of the most common helminthic infections in humans, with nearly 1 billion people affected worldwide. For us, understanding its life cycle, the pathology, the diagnosis, and complications is crucial both for exams and for clinical practice. We will focus not only on clinical aspects but also on how it appears in radiologic imaging, which plays a crucial role in diagnosis and assessment of complications. Now, coming to the etiology. Ascariasis is caused by Ascaris lumbricoides. Ascaris lumbricoides. This is the largest intestinal nematode of the humans. Adult male measures up to 15 to 30 centimeters, while adult female is even longer. It measures about 20 to 35 centimeters. These worms reside in the small intestine. The life cycle is direct and does not require an intermediate host. Humans are permanent hosts. Humans become infested after ingesting material contaminated with embryonated eggs from feces of an infected individual. The eggs then hatch into the larva in small intestine under the influence of gastric secretions. These larvae have the capacity to penetrate the intestinal mucosa and are transported hematogenously to the lungs. The worm then matures in the alveoli and then travels up the bronchi and trachea only to be swallowed again. After swallowing, they reach the intestine. Once in the intestine, they mature to adult worms. These adult worms are now capable to produce eggs. These eggs are excreted along with the feces and then swallowed by another human, thereby completing the cycle. So remember, the life cycle is direct. It does not require any intermediate host, and humans are permanent host. Intermediate host not required. Also remember, pulmonary migration is a classic feature of this worm. Now in next slide you are able to see that first the human has ingested this embryonated egg. Then the embryonated egg, as soon as it reaches the stomach and intestine, it hatches into the larva under the influence of gastric secretions. Now this larva is very naughty. The larva penetrates the intestinal mucosa, and after penetrating, obviously it will enter in the bloodstream and hematogenously will travel into the alveoli. So remember, the favorite place of Ascariasis is alveoli. In alveoli, then it matures into slightly bigger worm and then retrogradely travels through the bronchi into the trachea, which generates a foreign body sensation to the human, and there is a cough reflex. And then the worm is now swallowed again, and this time as an adult worm. The worm then reaches the small intestine and resides in the jejunum precisely, where it develops in its full potential and is now capable of laying eggs. These eggs are again secreted in the feces, and these then reach through the contaminated food and water to the another human and thereby infecting another human. So this is all about the life cycle. Now coming to the clinical features. Most infections are asymptomatic. When symptomatic, they present in two phases. Remember, the first phase is larval migration phase and it leads to Loeffler's syndrome. Loeffler syndrome is nothing but an allergic reaction wherein there is transient pulmonary eosinophilic infiltration predominantly in peripheral lung fields. So in this Loeffler syndrome, the patients will clinically present with cough and wheezing, and on blood examination there will be eosinophilia, and on chest x-ray there will be peripheral lung field infiltrations. Hazy opacities will be noted in peripheral lung fields. Second, there is intestinal phase. So in intestinal phase, patient will present with abdominal pain, nausea, malnutrition, anemia because the worm hampers the iron absorption. Also, the heavy worm load clumps together and cause intestinal obstruction. Again, revisiting some important facts so that we can better understand the clinical features and complications. So, remember that adult worms mainly live in the jejunum but may occasionally reach the ampulla of Vater due to altered small bowel motility. And when they reach this ampulla of Vater, they can from here on migrate either into the CBD or into the main pancreatic duct. So, when they obstruct the CBD, this leads to cholangitis, cholecystitis, or obstructive jaundice. And when they infiltrate into the main pancreatic duct, it leads to pancreatitis. Also remember another rare complication, which is hepatic abscess. It occurs due to superinfection of the dead adult worm in hepatic parenchyma. Now again elaborating the complications. First we will read about the intestinal complications, that is anemia and malnutrition. Thereafter the mechanical complications of intestine, which are bowel obstruction, volvulus and intussusception. Next, coming to the ampulla of Vater complications, which are pancreatitis, cholecystitis and liver abscess. Then the rare complications are acute appendicitis, airway obstruction and cardiac tamponade. Now coming to the main part, which is radiological aspect. So on X-ray, remember there are two phases of Ascariasis in human. First is larval migration phase and second one is intestinal phase. So first coming to the larval migration phase. In this, the chest X-ray shows transient fleeting patchy infiltrates which are most often peripheral, and in blood investigation eosinophilia will support our diagnosis of Loeffler syndrome. Then coming to the intestinal phase. In intestinal phase, we can see tubular soft tissue densities within the distended bowel. However, it is very rare to see that. Another point is that occasionally the dead worms become calcified, and during this time we can very well diagnose the pathology. Also, I have already told you that sometimes when the load is heavy, the parasites clump together and cause bowel obstruction. So on X-ray we can also see the signs of bowel obstruction, which are bowel dilatation and air fluid levels. Next, coming to the barium study. On barium, worm appearance depend on whether its alimentary tract is empty or distended. If alimentary tract of worm is empty, the worm appears as a filling defect. And if the alimentary tract is distended, the worm appears as parallel bands. Now look at this image. This is the small bowel follow through image, and you can see that there is a linear filling defect lying in the small intestine, and it is consistent with the finding of a intestinal worm, most likely Ascariasis. Next is ultrasonography. In ultrasonography, in longitudinal section, worm appears as 4 echogenic and parallel lines separated by 3 anechoic bands. This is known as strip sign, and when there are multiple worms, it is known as spaghetti sign. Also, there is an inner tube sign, which is because of distended fluid filled alimentary canal of the Ascariasis. So get it how well we can see the worm in sonography. We can even see its alimentary tract in USG. So the alimentary tract appearance is known as inner tube sign. Next, coming to the cross section. In cross section, the worm appears round, giving a target-like appearance. And during real-time evaluation, the worms can be seen making curling movements. Now, coming to the USG appearances. Again, revising the signs. This one is target sign. It is seen when we see the worm in cross section. Next is strip sign. In strip sign, we can see 4 echogenic lines separated by 3 anechoic bands. Next is spaghetti sign. You can see the curled worms clumped together in the intestinal lumen. Now one by one we will be revising these signs again. So this is strip sign. You can see the worm as parallel echogenic lines with the inner tube sign in the center of the worm representing the alimentary tract of the worm. Next, coming to the cross section image. When we see in the cross section plane, the worm appears as a rounded structure, which is the cross section of the worm, and it gives a target like appearance. Next, again look at this USG image. This one is the worm and this one is its curved tail. Next, again look, this is the worm with the strip sign, 4 echogenic lines with 3 anechoic bands and the inner tube sign. Again look at the images. This one is a video. You can see the curling movements of the worm, and this worm I encountered just a day before and it was approx 20 to 30 centimeters long. Can you imagine? Next, you can see that this linear echogenic band is seen in the gallbladder lumen, representing Ascariasis has reached the gallbladder lumen. Now coming to the CT appearances. So in CT, it is seen as linear or coiled filling defect in intestine or biliary tree. Secondary findings include bowel obstruction, biliary dilatation and pancreatitis as per the site involved. So this is a CT coronal image and it shows multiple clumped linear hyperdensities which are obstructing the bowel lumen. And why is this hyperdense? Because it has adjusted the oral contrast which was given to the patient. Next is this biliary ascariasis causing IHBR dilatation. Next, coming to the MRI. In MRI, worm appears as linear hypointense filling defects. So here is a case of biliary ascariasis on MRCP, and you can see a linear hypointense filling defect in CBD causing mild IHBR dilatation. Next, again, this faint linear opacity is representing a worm and it is also causing mild IHBR dilatation. Again, this is the worm and this is causing mild IHBR dilatation. Coming to the treatment. Single 400 mg dose of albendazole is the drug of choice and treatment of choice. Next, surgery can be done if there is bowel obstruction. And third, endoscopic removal is indicated when there is biliary or pancreatic involvement. So to conclude, Ascariasis is not only a clinical diagnosis but often a radiological one. Plain films, ultrasound, CT and MRCP all provide characteristic appearances that when recognized can prevent life-threatening complications. So that's Ascariasis in a nutshell, from etiology to treatment to diagnosis. If you are preparing for exams, focus on the life cycle, Loeffler syndrome, complications and egg morphology. These are high yield points. Now let's quickly jump to a MCQ session. So first question is, Ascariasis is caused by what? Options are Trichuris trichera, Ascaris lumbricoides, strongyloids stercoralis and Encyclostoma duodenale. So answer is B, Ascaris lumbricoides. Next question is, hepatopulmonary migration of larvae is seen in which? Options are Enterobius, Ascaris, Trichuris or Tinea. So answer is again B, Ascaris. Third question is Loeffler syndrome is associated with which one? Options are malaria, amoebiasis, Ascariasis and dengue. So answer is again Ascariasis, option number C. Question number 4. Which drug is used as a first line treatment in Ascariasis? Options are albendazole, praziquantel, metronidazole or niclosamide. So answer is A, albendazole. And what is the dose? 400 mg single dose. So that is all for today. Don't forget to subscribe for more